quite pressed for time, but this is obviously my favorite topic. It includes teratology and genetics in one go. And I think we're very fortunate to have the opportunity to talk about this today. So I'd like to present to you TeratoPHEN, which is our demonstration 4 project within Work Package 2. And the focus of this is really about highlighting the importance of better delineating teratogenic syndromes. So really understanding beyond just major birth defects, what effects teratogens have on human fetuses. And the name is derived from teratogen plus phenotype. And a phenotype, for those of you who are not familiar with the term, is a widely used genetic expression which describes a recognizable pattern of features. And a good example of a phenotype, which I think most people in the audience might recognize, is that of Down syndrome. So as soon as you see this pattern of facial characteristics, one would immediately understand that the individual probably have learning difficulties and may have associated medical problems. So really understanding the linked features is key to care. On the other hand, if we look at most human teratogens, I honestly don't think I can say that I am confident about the full phenotype that those exposures result in. And why is that? Possibly because once a medication is identified as teratogenic, there's no system for long-term follow-up or detailed phenotyping of the original cases in the current pregnancy pharmacovigilance systems. And really, this work has historically been left to researchers or interested clinicians to do, and that can be incredibly challenging in terms of coordinating such projects, obtaining funding, getting through ethics, etc. And as a consequence, natural history and other features are not well documented. And this impacts on the ability to recognize and diagnose new cases. And of course, most importantly, there is a lack of information often for patients and families and healthcare providers to support evidence-based clinical care and decisions. And in the real world, we know that just because pregnancy is not recommended, it doesn't mean that it won't happen. And there's several scenarios in which that can occur. And one of the other benefits of what we call deep phenotyping, so really detailing the effects of a teratogen, can be shown from examples in genetics, where we deal with a lot of rare diseases and we have to really work hard at finding patients with those conditions and putting the information together. And this is a leaflet produced by an organization called Unique, which I think beautifully illustrates how useful these details can be to families and in terms of informing management plans when you don't have large numbers that allow you to do statistical comparisons. So what is deep phenotyping and why do we do it? So deep phenotyping is about very precise and detailed characterization of features, and that could be biochemical, it could be developmental. We've just heard from Rebecca how important that is. That also takes into account how these features might change or evolve over time. And a really good example of this is a photo from a patient I saw a number of years ago who came to clinic at age 6 and essentially looked quite or no distinctive features. And we asked mum for both baby photos, and it was then apparent that the little boy had a ridge on the forehead, and there was an exposure of antenatally to sodium valproate. And this really helped to reaffirm the diagnosis of fetal valproate syndrome, which had become less obvious over time as happens. And that's what we call the natural history of a condition. So we need to better understand how features maybe change. And deep phenotyping is also increasingly important because we're starting to move towards precision medicine, where pharmacogenetics allows us to predict responses. In an ideal world, what we're looking for is that the medicines that women are offered will be effective in pregnancy and not cause side effects in the mother, and of course also not cause any harm to the baby. And in some instances, treating a maternal illness is actually protective against the teratogenic effects of the illness itself. So there is a lot of interaction between genes and teratogens or medications. So the genetic makeup of an individual might determine how they respond to the medication. And equally, medicines, we know alter genetic pathways, and there are examples such as thalidomide, where we see that is the mechanism underlying limb defects. And on top of that, I think that we must remember how important teratogenic studies have been. So exposing animals to harmful drugs and historically in terms of understanding human development. And also the fact that we can't always predict what effect a drug might have on a baby just based on what we know about how it works therapeutically. And again, understanding the genetics behind this has really helped advance us in this area to develop better and safer treatments. And I think this interplay is really well highlighted with an example of microphenolate embryopathy, which really closely mimics clinically a genetic condition known as CHARGE syndrome. So if you saw a child with this list of defects and you didn't know anything about the exposure, you wouldn't actually be able to make a confident diagnosis. And we talk about this being a phenocopy. So phenocopies are features that are caused by a drug that mirror those seen in a genetic cause. So it's easy once you know that a drug is teratogen to say, look, this is probably the cause of the child's features, but it's very, very difficult in those initial cases. And in these situations, genetic testing to exclude a genetic mutation, or certainly to look as well as you can for one, is key. And you can see how similar these two conditions are, and that they both work by affecting the embryo in a similar way. I think the one big difference here, which again relates back to Rebecca's talk, is how we have no knowledge of neurodevelopment in children with microphenolate embryopathy that has been collected, so no developmental information that's been collected systematically. So why are geneticists and genomic analysis important in future pregnancy pharmacovigilance systems? Well, geneticists have experience in deep phenotyping, which we know is going to become increasingly important. And also, it's really, really important in those early cases to exclude a genetic explanation, so to exclude a genetic cause for the child's features, not only for the family and patient, but also in terms of pharmacovigilance, because we risk otherwise losing effective drugs from the market where there is a false association with a certain potential teratogenic effect. And we see increasingly that queries that are coming through are becoming increasingly complex. So for instance, questions around whether a bulk rate might in fact not just affect the sequence of a gene, so the letters in the gene, but actually the changes that control how genes are switched on and off, and which we know can be passed down from a parent to a child. And so this is, a huge area of future interest and concern. So how can existing networks and infrastructure be better leveraged? So what we're doing in the TeratoPHEN project is working with a well-established group known as the Decipher consortium, which is led out of Cambridge, which is now well-established globally and hosts a database that geneticists have used to overcome the challenges of collecting information on patients with rare disease. And you can see this is a screenshot of the Decipher consortium. You can see how powerful this network is in terms of accessing expertise and being able to capture information about patients. And what we're doing is we're adapting the Decipher database that was primarily designed for genetic studies to make it suitable for collecting information about drug exposures in pregnancy. And the database also allows patients or clinicians to upload patient photographs, obviously with consent from the family, and is looking at using computer analytics to define or diagnose conditions using facial recognition software. And you can see here that unlike all the other databases that we are used to working with, this database has codes that really allows you to deep phenotype the patient and put in very, very precise information. So the pilot study involves us looking at the existing database, making the changes that we see that it needs, aligned with the core data elements that you've heard about before, so the minimum information that's required. And we also know that Decipher contains patients with exposures to teratogens such as valproate, because for a long time we needed to be sure, and still to this day, that those children don't have other coexisting genetic disorders. So we're going to look at what's in there, and we're going to test the ability to use this network to communicate with geneticists around the world, to ask them to upload information about patients exposed to teratogenic medications. And by doing that, overcome some of the delays in the system that we've seen in the past due to a lack of an astute clinician platform. And there might even be the possibility for us to look at using bioinformatics to plot and analyze some of this information. And these are just some of the examples of the outputs of the database that compare the trajectory of patients with a certain condition against the general population. And this is another feature which is really powerful. It's something called the matchmaker exchange, where if I saw a patient in clinic and they had birth defects following exposure to a new drug, I could then put out a query to the database to ask whether anybody else in the world has seen something similar, or to look and see if somebody's reported something similar. So it really will, I think, change things going forward. And this is only going to be effective if we're able to establish a global collaboration. Unfortunately, geneticists, work closely together, and we have a number of networks who we are already linked into, who will be able to hopefully support and contribute to these initiatives, including GAMPS in the USA and Abomu Bushle in South Africa, which is a registry which has been developed initially on the back of the Volutecovir queries. So we hope that by establishing this network, we will avoid the repeat of the difficulties that we've faced with trying to interpret historical data sets that aren't of the quality we need, and that really using the structure will help to improve identification and delineation of new teratogens, as well as those that we know about already. So I'd like to move to some questions just to obtain your feedback on the role of genetic testing.